Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Moderna, Inc.
Hello, I'm Dr. Megan Pesch, Assistant Professor of Developmental and Behavioral Pediatrics at C.S. Mott Children's Hospital, which is part of the University of Michigan Medical School in Ann Arbor, Michigan. Welcome to this program titled What You Need to Know About Cytomegalovirus, or CMV, in Pregnancy. It's part of our series, Let's Talk CMV. Joining me today are Dr. Natalie Aziz, who is a Clinical Associate Professor of Obstetrics and Gynecology at Stanford University School of Medicine in Stanford, California, and Dr. Malavika Prabhu, who is an Assistant Professor of Obstetrics and Gynecology at Massachusetts General Hospital in Boston, Massachusetts. Welcome to both of you.
Thanks for having me.
Thank you, Dr. Pesch.
As we know, cytomegalovirus, or CMV, is a very common virus that infects and affects people of all ages in the US and really worldwide. Most people with CMV, when they get the infection, they have no symptoms, so they're really not aware that they've been infected. But pregnant women with CMV may pass the virus through the placenta to the fetus. And then most babies who are born with congenital CMV, thankfully, never show signs or have health problems, but some do actually develop health problems later on. So around 1 in 200 US babies are born with this virus, or around 30,000 US infants a year, which is, a really high number. So Dr. Aziz, I wanted to open by asking you about CMV in pregnancy and how common is it?
Well, it's very common. So there are differing studies, but on average, about 50 to up to 70% of pregnant women have had the infection at some time in their lifetime. Additionally, the about 2% will get infected in pregnancy.
And why is it important to know about congenital CMV?
That's a great question, Dr. Pesch, and I would say that everyone needs to really know about congenital CMV. It's the most common infection that leads to disabilities, and it's the leading cause of congenital hearing loss. And in addition to hearing deficits, there are children that can have vision deficits, cognitive impairment, motor and neurologic issues like seizures, and at least 1 out of 5 of the infected babies will have long-term, lifelong disabilities.
It's an important cause of fetal loss. And from a pregnancy perspective, it's more common than many other diseases that actually we worry about a lot in pregnancy.
I think the fetal loss thing is so important. I think research more and more is kind of showing us what an important under-recognized contributor congenital CMV is. So where are we now with CMV screening during pregnancy? What are ACOG and the Society of Maternal Fetal Medicine, what are those guidelines saying?
The guidelines do not recommend routine serologic screening for CMV in pregnancy. And there's lots of reasons why that might be the case. For CMV, it's hard to know what some of these tests mean. They're not easily interpretable. And it isn't clear that there is a standard of care therapy for pregnancies in which we may be concerned. And, not to mention the fact that this might be an expensive test, we may cause a lot of patient anxiety for what is ultimately an important cause, but still probably most people's babies are not going to have this disease.
And in your clinical practice, under what circumstances would you test a patient for CMV?
Right. So I think testing means we got to be worried about something. So a few different scenarios are the patient comes in, she has a fever, she's got some swollen lymph glands, she's generally feeling run down, maybe flu-like, maybe mono-like. It would help if the patient had a very helpful social history, like, I've got a toddler at home, I work at a daycare, I'm a teacher. Unfortunately, not everyone has that story. but those patients should certainly get tested. So one group of people is symptomatic in some way, shape, or form, and fever is probably going to be the most frequent trigger. Another group of patients is the asymptomatic group who have an ultrasound finding. The typical time to have an ultrasound finding is around that 20-week or midpoint of pregnancy when we do the big anatomic survey. CMV can cause some birth defects to be noted or concern for birth defects to be noted on the ultrasound, and that would be a good time to test. And then there's two other groups that I think about. One is a patient who has maybe some elevated liver function tests, hepatitis type findings. It's hard to know really what to make of that. And especially early on in the pregnancy, it's definitely not preeclampsia, which is what obstetricians think about when we think about liver functions being abnormal. And then the last group, honestly, probably does fall a little bit more into that screening group, but that's the group of patients who ask you for a CMV test.
Mm-hmm.
They don't have a symptom, they don't have a fever, they haven't, gotten to their 20-week point, but they express some concern, and that concern can range from it happened to my friend. And that last group is a little bit trickier to counsel in the sense that there are some pros and cons to testing this asymptomatic group.
How do you go about testing for CMV during pregnancy?
I like to test with the CMV, IgG, and IgM antibodies, and I do like to get quantitative values if possible so that we can trend those levels as needed. CMV, IgG avidity testing is helpful when both IgM and IgG are positive to try to help give us the chronicity or the timing of the infection. And of course, PCR is also helpful in case there is a difficult time, again, interpreting the antibodies and the avidity. Sometimes PCR can be used to help identify whether the infection is actively ongoing or if there is no evidence of DNA in the patient.
And then the last test that's in our back pocket is doing an amniocentesis. But it'd be so uncommon to start there. We'd really need to be worried about the pregnancy, find a lot of abnormalities on the ultrasound.
What are some of the drawbacks of routine prenatal screening for CMV?
First of all, from the patient's perspective, I think sometimes what they're looking for is to say, I am not at risk for CMV. I got this blood test done. Good news, I'm not at risk for CMV. And taking a step back, I think the truth is that no blood test can tell the patient that for this particular infection, even though we'd like to think once we've had it, we're immune. I do think what this test can tell you is, well, have you never had CMV? Are you totally susceptible? And then on the flip side, I think we may find a lot of blood work that is hard to interpret. And the chance that any pregnancy is affected is really quite low. I think comparing that to the chance that we stress a family out with incomplete information or information that's hard to interpret in an ultimately healthy fetus cannot be underestimated.
What are the differences between a primary and then a non-primary CMV infection?
That's a great question. So primary is that initial infection in an individual who's never seen CMV before. They've never had the infection. They were IgG and IgM negative prior to their infection. Non-primary is more challenging. It includes both reactivation and reinfection. So a reactivation non-primary infection is when you have latent CMV in someone who had it prior, but then it's reactivated at a later time. And then the second part of a non-primary infection is that reinfection aspect, is when a seropositive person acquires a new strain of CMV from someone else or a superinfection.
I think that is really helpful to differentiate the reinfection and reactivation.
How do you discuss primary versus reinfection versus reactivation in terms of CMV infections with your patients?
It's pretty tricky to explain. Many patients actually have a good understanding of, the difference between genital and oral herpes and how those two herpes are related, but not the same. So I actually often start there and kind of assess like, what do patients know about that? And then just kind of saying like, we think, or we know if we did serologies, that you've never had CMV before. So if you got CMV in pregnancy, this would be the first time you've ever had CMV or your primary infections. What's harder to swallow is the fact that, oh my goodness, the CMV's in my body still, even though I don't have symptoms. Can't you get it out of there? And I wish that we could, but that is harder to explain, how there can be latent infections. But I think people have a good experience with family members, especially older family members, getting reactivation zoster. So I often talk about that and how this is a little bit like that. You can reactivate. And then reinfection. I think COVID has made our lives a little bit easier in the sense that now people know all about the strains of viruses. So breaking it down like that, in my experience, has been helpful.
What is the risk of a fetal infection following a primary maternal infection during pregnancy?
On average, we quote about 30 to 40%, but it definitely depends on the timing of the pregnancy and the timing when the infection is acquired. So in the first trimester, it's probably closer to about 35%, whereas in the second trimester, as the placenta has a larger mass and there might be more potential for transmission, it goes up to 40%. And in third trimester, it can be as high as 60 to 70%. The one thing that's very important to remember is that CMV acquisition preconception can also still lead to fetal transmission, in that you're still shedding or you're still viremic up to perhaps maybe 4 months, even if prior to pregnancy. If one is infected, they can still have the risk of transmission to the fetus. Fortunately, it's not as high as 30 to 40%, but it ranges between 5 to about 15%, depending on how close you are to the timing of your conception and when you acquired CMV primary infection.
What about a non-primary, so a reinfection or with a new strain, or a reactivation?
Fortunately, that number is a lot lower. Studies range between about 0.15% to 2 or even 3%, but generally for most studies, it looks like it's about 1%. And the most serious fetal sequelae occurs when the fetus is in the first trimester and perhaps early second trimester, in that where all the organogenesis is occurring.
I just wanted to run a few clinical scenarios by each of you. What would you do if a pregnant patient came in and said they were concerned about CMV? So this is an asymptomatic patient. Would you test? And if so, what kind of tests?
I would listen, I would ask questions, and I would risk assess and see what the true risk may be of CMV, and to also discuss that even if we tested for someone who's asymptomatic, didn't have any risks, even if they were immune, it wouldn't be fully protective anyhow. So it's not extremely helpful for how we would still continue to manage and counsel a patient. Now, on the other hand, if the patient's risk is high, she's had a toddler who came home from school and could definitely have had a infection with CMV, then in that situation, I would absolutely test, and also assess with ultrasound as well if the test is positive in some capacity.
I think I'd be curious about what's prompting that question, but depending on what the patient says, I think sometimes you can reassure patients without getting blood work. And sometimes I think the patient probably does deserve the blood work. She tells you like, well, I already have a kid at home. My kid's fine, but I'm having to send my kid to daycare, and my friend's kid had it. And I'm just like really worried that I'm going to get CMV from my kid. And I know I'm supposed to wash my hands, but can you just tell me if I've had it already? And I think that that's a patient that I would talk through all of what you and I have already spoken about in terms of pros and cons. So I think after explaining, my perspective on it and a little bit why ACOG doesn't say just willy-nilly send the test, I would send the test. I would just do serologies, IgG and IgM, with reflexivity if the IgG is positive.
That's great. Really, that shared decision making is so key.
What would you do if a pregnant patient came in with flu-like symptoms while pregnant?
In addition to the flu, I would also test for CMV, and I would test with IgG and IgM quantitative serologies. And just depending on how long she's had these flu symptoms. So if she's had them only for a week, I would also add on a PCR quantitative because she may not have had enough time to seroconvert her IgM, for example, if it's just a recent infection.
Wow, right. I think that's not something that I've thought about, but that is a wonderful point. And last clinical scenario, what do you do when you see fetal abnormalities on ultrasound? What would make you test and what kind of test you order?
So things that we can see on ultrasound for an infected fetus would be possibly fetal growth restriction, echogenic bowel, ventriculomegaly of the lateral ventricles. We can also have ascites or fluid in the abdominal cavity. We could also potentially have hepatic multiple calcifications, for example. So those types of findings would veer me to, first of all, counsel the patient and both offer her personal testing, but also discuss the option of an amniocentesis.
And then after that, if the amnio comes back positive, what are your next steps, for caring for this patient?
So obviously, close surveillance of the fetus is important with ultrasound to continue to look for fetal growth restriction, for example, or if it exists to perform surveillance as deemed necessary for fetal growth restriction. If there are any brain findings, we also like to offer patients an MRI because that can add to our information and can give a better delineation of the exact brain effects that might have occurred, as ultrasound is not perfect at seeing the CNS as MRI is. And then, you have that difficult conversation, obviously, with discussion of pregnancy options and depending on gestational age, for example. And there's a lot of discussion also about what studies have been conducted, although there's no standard of care yet for treatment of fetuses who have an infection or the prevention of fetal infection if a mom has a primary infection. And then finally, we also like to do a referral to pediatric infectious disease so that they can also discuss the treatment options for an infected and symptomatic infant.
So it's really that shared decision making and the multidisciplinary approach of bringing in all the experts to give the family the information that they need. Before we close out, what would you say to a patient who is thinking of becoming pregnant?
Well, I think it's important to both consider these discussions in a preconception and also during the pregnancy, and especially first trimester periods.
Yeah, I think it's back to the basics. So it really is just about hand hygiene, making sure, if you somehow get in contact with bodily fluids, to wash your hands properly with soap and water, especially if it's with another kid. But we always poo-poo prevention, but prevention really makes a difference in this particular setting. And I would emphasize that this starts before pregnancy. Don't wait until that positive pregnancy test to change your behavior.
I think that's a super critical message. Start early, start before the pregnancy. That's great. Well, thank you both for this great discussion. I really appreciate both of you sharing your expertise.
It's a pleasure to be here. Thank you so much.
Thanks so much for having me.
And thank you to our audience for participating in this activity. There are also other podcasts in the CMV series that discuss screening and testing for congenital disease in newborns, as well as what to do if a baby is born with congenital CMV. Please Please continue to answer the questions that follow and complete the evaluation. We really appreciate your feedback as it helps us develop future educational programs.